Hello, and thank you for the opportunity to present our work here today. My name is Michael Pflüger. I'm a research fellow at Johns Hopkins, and I'm excited to share with you the results of our study on the management of proton pump inhibitors after anti-reflux surgery. I have no personal disclosures for this talk. And anti-reflux surgery, or in brief ARS, is the gold standard for the treatment of gastroesophageal reflux disease that is refractory to medical treatment. It's safe, it's effective, and it's been shown that this provides sustainable results, and it's a quite common procedure that is performed in the United States each and every day, numerous times. As you may have encountered in your own clinical practice, patients that are scheduled for anti-reflux surgery oftentimes take proton pump inhibitors before undergoing the surgery. And with the anti-reflux surgery, we can actually restore this anatomic and physiological anti-reflux barrier, which then eliminates the need for the use of proton pump inhibitors after the procedure. This is awesome because if we consider the potential side effects or the cost of, or especially long-term costs of PPI intake, this provides a significant advantage. When we talk about the discontinuation strategies of proton pump inhibitors, there's usually two types of strategies that are entertained. One of them, you can see that on the left side, is the abrupt discontinuation, kind of the hard stop strategy. And on the left side, you can see the gradual discontinuation, the tapering down, weaning the patient off the medication. If we look into the literature, actually, there's quite some data out there. You can see here on the left side, there's a small randomized trial. There are some expert recommendations, even from societies out there. And the main problem is that actually those studies and recommendations only apply to non-surgical patients. So this is only in the medical literature, and really, unfortunately, there's no information out there how we best can discontinue proton pump inhibitors in our surgical patients. And I think it's quite intuitive that we cannot simply take findings that were, or scientific studies that were done in non-surgical patients and just apply those to our surgical patients. This is especially important because we're really dealing with patients that are suffering from severe GERD usually. They have a PPI intake for several years, often at high doses. And we can, as surgeons, stop the reflux immediately, but that certainly comes inherently along with an altered gastrointestinal anatomy, which makes our surgical cohort special. Again, in the absence of studies, of guidelines, of any other recommendations, we're asking ourselves the questions, what is actually the current practice? What are providers doing throughout the United States when it comes to discontinuation after anti-reflux surgery? We designed a survey, and we're interested, of course, in the postoperative PPI management of the providers. We're interested in the discontinuation patterns, but also in the timing. And we also were interested to explore a little bit the reasons behind the decision-making. The complete survey had about 7 questions, depending on the previous answers. It took about 2 minutes to complete the entire survey, and our survey was open for 11 weeks. We used an online tool called Qualtrics, a software which essentially allows us to create a study that we can then distribute via an online link, and that can be accessed online. And this also allowed us to anonymously record the responses of the respondents. We sent out this survey link to 644 providers, and since our goal was really to target experts, Foregut experts, Foregut surgeons for that matter, we also shared the link on some social media platforms and societal platforms to target this group. Maybe some of you in this room here may have participated in that study because we also shared it via Sages. We were actually able to get responses from 121 respondents, and as you can see here, we achieved our goal of getting the opinion of surgeons, hopefully expert surgeons, but 92% actually of our respondents were surgeons. The first question we asked them was, what is your current practice? How do you discontinue PPIs after anti-reflux surgery? And you can see here in this first bar in red, 42% always and immediately discontinue PPIs after surgery. The second group on the bottom, the blue bar, you can see here that 58% in fact do not always and immediately discontinue. And of course, we were interested in what do they do instead, or how do they do that? So we looked a little bit closer into the second group here. So we saw that 46% actually always wean or taper, Whereas, so they favor the second approach that you've seen on the right side in the previous couple of slides before. And 47% decide for a selective approach. So they decide a little bit on a case-by-case basis whether they're going to wean or taper. Interestingly, also 7% of providers said that they would never discontinue PPIs after anti-reflux surgery. We looked a little bit into this second group, into this first two groups again, that always or selectively wean or taper, and we are interested how do they do it in terms of timing. And it was quite intriguing that 92% discontinue the PPIs within the first 3 months, whereas less than 10% wean the patients off the medication after a period that's greater than 3 months. So if we take all this data together from the respondents in terms of timing, we can see that the vast majority, in fact, of providers discontinues the PPIs within the first 3 months of anti-reflux surgery. As I mentioned before, we also wanted to look a little bit into the reasons and why some providers favor one regimen or the other. And we asked the question, what was which factors have the largest influence on your PPI discontinuation protocol? And 39% of respondents said that prior training and mentors would have the largest influence, whereas 42% said anecdotal evidence or any personal preference would have the largest influence, whereas 19% said that the primary driver for their protocol would be medical literature or evidence-based medicine. And let me just make 2 comments here about these findings. So first, as you can see, the first 2 groups, which is actually the vast majority, 81%, they are citing very low evidence levels here. So you can imagine anecdotal evidence is kind of the lowest evidence level we can have, if you would call it evidence in the first place. And then if you look into the last group here, the third group that said, oh, actually I make my decisions based on medical literature and on evidence-based medicine, it's a little bit unclear which evidence they're referring to. Most likely they're referring to the literature that's out there for the non-surgical patients. We also looked into other factors that influence the decision, especially when we talk about the group that goes for a selective approach. And I just want to highlight a few points here. The surgery technique, although there's a magnitude of different approaches out there now, actually had not really a large influence. And the dosage of the preoperative PPI use was more relevant for providers than the duration of preoperative PPI intake. Lastly, it was really reassuring that numerous providers also recognized the importance of esophageal pathologies and to adjust the regimen accordingly. What are the main takeaways here? Certainly that PPI discontinuation after anti-reflux surgery is the standard of care in the United States, at least in this expert group that we asked. And the discontinuation takes place within the first 3 months of surgery. The 2 protocols that I showed in the beginning, they're quite equally entertained, in fact, about a 50-50. And while we can certainly not make any recommendations which regimen is better, and there's further studies needed, it's interesting that there's quite a 50-50 situation here. Lastly, these decisions are mostly driven by training and experience, so there's clearly a need for better tools, for more studies, to really make evidence-based recommendations. And with that, I would like to thank my mentors at Hopkins, and I'm happy to take any questions. Thank you.